as you know, was intended to rebuild and transform a aged and outdated healthcare system and figure out how we can best deliver services to Newfoundlanders and Labradorians. And I do believe that we've moved the dial significantly on that project. And we had a lens that gave us a big picture. Oh, there we go. How's that better? The lens of the health accord gave us the ability to see a bigger picture. It was a 10-year roadmap to achieve improved health and well-being for all residents by integrating and modernizing our healthcare system. And I'm happy to note that since the Health Accord report was published 3 years ago, we have been steadily implementing its recommendations and are already seeing significant progress. And that is no small task. The folks who have been working within the system have adapted, they've moved and changed, and all while we're trying to make these big transformational ideas in the system continues to provide care. So I'd like to take the opportunity to say thank you to all the individuals who've been working day in, day out, not only to make these transformations possible, but to hold the line and continue providing services here in Newfoundland and Labrador. But we have done some incredible things. For example, as of this summer, more than 100,000 people are now connected to family care teams. That's approximately 20% of our province's population that all have a family care team to call home. Just yesterday, I was happy to join the Premier as we announced a new funding model for nurse practitioners, which will further improve access to primary care for residents here in our province. And I know that the emergency department diversions all across the province have come down. We had, on average, a decrease from what was 1,432 hours per month in 2022 to now 34 hours per month in 2025. That is a significant amount of progress. Joint replacement surgeries completed has exceeded the new referrals for the first time in 24-25, and we have increased volumes of cardiac surgeries being completed. 2 radiation oncologists have been recruited for Corner Brook, which will help people receive radiation therapy and consultations and follow-up appointments in the Western Regional Hospital. More than 14,000 people are able to see their health information on My Health NL app. And it is it's a pretty cool thing to have access to all of your information in the palm of your hand. We know there's room to grow and develop that app, and we're excited to see what the future holds, but to know that people can now see their test results and have that information, it was a very important piece of the puzzle. And we have an increase of 7% in the physicians licensed here in our province since from 2021 to now in 2024. We have 1,771 physicians licensed this year. So there's some incredible things happening, but there's certainly more work to be done. I don't stand here in front of you claiming to say we have it all fixed, but I do stand and say we have a plan. And often you hear criticisms that there's no plan, or what are you doing, or are you just flying by and making decisions on the fly? But that is certainly not what has happened in the healthcare system. Guided by the solid evidence and information in the Health Accord, the teams who are part of Health and Community Services have been able to move the dial and make important decisions. So we've got a number of things that are still left to discuss and talk about, and if you'll stay tuned, we do have an update on the modernization of the integrated air and road ambulance system that'll be coming soon, and I'm very excited about that one. That's very close and near and dear to my heart and my district, but keep your ears open for that one, and I'll leave it to Dr. Parfrey to give some more information on where we stand in terms of the recommendations, what has been implemented, where we're going, and some of the prospects for the future. So I'll pass it over to Pat Parfrey, the CEO of NL Health Services, and he will provide you with all of the details on where we are with the Health Accord.
Hello, everybody. The bad news is this is going to take at least 30 minutes, 30 to 35 minutes, because it's a big plan with lots of pieces to it, and some of the details need to be assessed and determined. We've given you the slide set. The media have the slide set. You can use them, and the highlights, and we're going to put this presentation on our website as soon as we're capable of doing so. And we're fully open to whatever questions you want in further detail to discuss the components of it. I'd just like to remind you that although Sister Elizabeth and myself were the co-chairs of this task force, it involved 128 people who represented the political parties, the unions, the public, the healthcare delivery system, the medical school, etc. And we came forward with an agreement that we would have 59 calls to action that we would try and recommend to government for implementation, and then hope that we were capable of actually implementing them through either the health system or the social system. And the essence of the health accord can be summarized as follows. We wanted to increase awareness and intervene in the social determinants of health, and we wanted to rebalance the healthcare delivery system across acute care, community care, and long-term care. So let's get into the report itself. So in 2024, we reported, in fact, Dave Diamond reported this with me, that we had in the policy to action cycle, that we had 26 actions started, 31 policy in progress, and 2 had not started. And now here we're a year later, we can demonstrate that actions have started in 34, policy development is in 25, and there's no actions not started. I'm going to talk about the community side first, and I'm only going to talk on this presentation about the healthcare delivery piece of it, because we don't have enough time to talk about the social side as well. And our intention is to provide a presentation on the social side during Wellbeing Week in a month's time. So the first major objective of the Health Accord and the healthcare delivery side was to try and improve care in the community. And that revolved around 3 things. One was family care teams, collaborative care teams. The second was virtual care to fill the gaps. And the third was an integrated air-ground ambulance system so that people felt more secure if they got sick in more rural areas. And our current situation for family care teams is that each budget cycle we got funding for more teams each year. We're now up to 23 teams approved, 21 are in various stages of operations, and 2 of them have not yet started. And the access has definitely improved. You can see here from this graph on the green line, you can see the number of people that were connected each month, going from just over 30,000 in May of 23, and we're now over 82,000 connected with a family care team. And at the same time, the orange line shows you the number of people that are on Patient Connect waiting to be connected to a family care team, and that's now decreased such that we're just around 40,000 people waiting to be connected with a family care team. That basic improvement in access is important, but there is far more to it than that. There is also the fact of whether people are working to their full scope of practice, whether they're functioning properly as a team, whether they're integrating services all across the community. All that stuff needs to be developed, more than what we're currently doing. I might also add there's an additional nearly 30,000 patients connected through 25 family physicians who have affiliated with the family care team but maintain their fee-for-service practice. Here is the information on virtual care. This is the graph that the Minister referred to, which was the hours of care, which is that top line, that were provided from 2022 up to the present. And you can see that in 22 and 23 we had very large numbers of diversions from emergency rooms. And look at the massive change. Very little diversions from now. And the top line shows you the number of hours of virtual care. So the combination of virtual care and being able to access staffing through agency nurses is a help to be able to diminish the amount of diversions from emergency rooms. Here's the information on the virtual emergency room visits that occurs by facility. You can see the facilities named on the right-hand side that have this virtual care, and the number of people each quarter that are enrolling. And you can see there that each quarter there's nearly over 15,000 people now in the last quarter have gone to an emergency room and have had their therapy through a virtual doctor. And we know that the people are happy with the care they're getting through that virtual doctor. Here is the data that we have around people who are accessing primary health care, continuing care, through a virtual doctor. And you can see here that the number is up to 7,700 people in the last quarter that we've got data from, which is from April to June of 2025. That's that top right-hand diagram. And that you can see in the bottom diagram that the access is occurring in all zones of the province. Now I'm going to move on to the ambulance system. And on the left-hand side, you had the traditional ambulance system that was not integrated, had multiple private providers that depended on the telephone. And these ambulances brought people to hospital who then were contacted to go to another hospital by plane. You'd have to call for the plane and then sort out a bed in the hospital. And we started this integrated air-ground ambulance system, which involves a provincial dispatch, dynamic deployment, proper accreditation, upskilling of paramedics, the planning for the integration of helicopters, improving medevac availability, having proper support systems, and a management accountability system in play. And I can report that in that bottom box there, that negotiations are near completion with Medavie for a 10-year performance-based contract for a data-driven integrated air and road ambulance system. And you should hear about this in the next bit of time. This is really important. We've integrated the ground. Now we're integrating the air, and we're having a management company manage both the air and the ground together. On top of that, the system that we've had for medical transport physicians has been ineffective, and I think the Minister referred to that is close to her heart to try and improve that medical transport physician process. We've hired a clinical chief for that medical transport. We're creating a 24-hour rota for doctors who will be on call 24 hours a day, who will communicate with the isolated doctors looking for help and the isolated family. And then that rota will provide three things. It'll provide ongoing care from the time the call has been given to the time the patient gets to the hospital. It will arrange the asset, whether it's ground or road, to transfer the patient, and it'll arrange the bed. So that system should be far more integrated, efficient, and capable of being able to solve the emergencies that are occurring in more isolated parts of the province. And on top of that, we're having a clinical coordination team that will try and make our interfacility transports more efficient. This is transformative if we make it work. So now that's the community side. So let's talk about the hospital side. I'm just going to pull out some examples of what's going on the hospital side, because again, here there's a lot going on. There's a lot of progress being made. And first of all, the provincial cardiovascular and stroke program are a really strong example of the tenets of the health accord and what we're trying to achieve. We want to try and bring people to the care as efficiently as possible through a better transport system, and in this instance through Heart Force One that you've heard about, and I'll give you some information on that. We also want to have rapid access clinics and rapid access to the hospital for people with emergency heart conditions. And then on top of that, we want to bring care to the people, which means that specialists go to the people and virtual care is used more. And that's occurred in this program as well to a fairly large extent. And the final piece of this diagram is a learning health system, which is, can we use the evidence of what we're doing to change how we do things for the betterment of the patients. And this program has got that developed. So now this diagram, I'll just show you, we'll take each box at a time. So this is about cardiac surgery. And the top right-hand box demonstrates on the left, in the dark green, you've got referrals, 2022-23. And then the light green, you've got the number of cardiac surgeries completed. And you can see there's a gap.
And that gap leads to a wait list. And that wait list had accumulated around 200. And here you can see in 2024-25, there's no gap, or tiny gap. And now the wait list has been got into. And I can report today, you can see on the left-hand side there in the box, in bold, you can see the percent increases that occur over time. But the key number there is the wait list at the end of August 18, 2025 is 137. And that is 132 outpatients and 5 inpatients, which is a sea change in how we dealt with cardiac surgery a few years ago. The other piece of information on this slide that's really important is that the time that people are waiting to get their procedure according to benchmarks, which is that bottom left lower diagram, by quarter in 2024-25, you can see that the black arc demonstrates that 95% of the people with cardiac surgery were done within the benchmark. That's a sea change.
The other piece of information that's really important is that we are trying to develop non-invasive approaches to cardiac surgery, like trying to treat aortic valves non-invasively through catheterization and improving the valve that way. And you can see in the bottom right-hand diagram that the referrals in 2022 was 58. And then when you get to 24-25, the referrals have gone way up to 117. But so is our capacity to do these procedures. We did 97 last year. That's a big improvement in the interventions that are available to Newfoundland and Labrador. Let's move on to the cath lab. Again, you hear a lot of talk about it. There's been a 7% increase of catheterizations in the last year, and percutaneous interventions, which is in effect trying to do a cardiac catheterization and insert a stent in the patient's artery. And that wait list has actually come down, and you can see here that the numbers done have gone from 3,248 in 2022-23 to 3,414, substantial increase. And there is a plan to open a 4th cath lab in the next few months, which will further increase our capacity to provide very efficient cardiac catheterization for one of the biggest diseases affecting our population. The lower half of this diagram, you can see here a pathway for providing stroke care. So if somebody gets a stroke anywhere in this province, the first step is to give clot-busting drugs, thrombolytics. And if the patient is outside the range to get those thrombolytics, there's a new therapy called endovascular therapy, which is specialized, has to be done in St. John's. A catheter is put into an artery and they haul out the clot. And that's called endovascular therapy. And you can see in the bottom right-hand table that the number that we've done per quarter has gone up in 2024-25 from 14 to 17 to 20. So this program has now expanded across the province. It's dependent on a good transport system, and it's dependent on being able to identify the people who need this therapy. The access issues. What's the data around access? So we have 3 streams to improve access. We've got, and that's the bottom left-hand diagram. So you've got low acuity patients who are in a hospital across the province who need to get cardiac catheterization to determine whether they need to get some kind of intervention. That's Heart Force 1. That shows there that we've moved from 6 flights in 2022-23 to 12 in 23-24. Now we're up to 24 flights in the last year and amounting to 168 patients. We started 2 more in programs. one for people who've got intermediate acuity, and one in particular for those people who've had a very serious myocardial infarction who need treatment within 24 hours, and they're dependent on the air ambulance system. And our approach to it has been to protect beds and to try and get these people in the air ambulance system. The traveling clinics. That diagram up top demonstrates that we've done one clinic, cardiology clinic in St. Anthony, 2 in Happy Valley, Goose Bay, 4 in Lab City, amounting to 300 unique patients seen in those cities. I'm going to move on from the cardiovascular and stroke program now to surgery. And this diagram may look complicated, but I'll abbreviate it by saying that the 10 priority procedures for the federal government are hip and knee replacement, cataracts, coronary artery bypass grafting, and cancer surgery. And you can see in the green that for the cancer surgery, we actually achieved the relevant benchmarks for the province compared to the country. But you can see that in red, we don't achieve the benchmarks times for the procedures to be done for hip and knee replacements, cataracts, and CABG. I've just, coronary artery bypass grafting, that's what that is. And I've just shown you the data which has demonstrated we're now reaching the benchmark for coronary artery bypass grafting, and we've increased our rate. So what about hip and knee replacements and cataracts? How are we doing in those instances? So on the left-hand diagram of joint replacements, you can see that we have had in 2023-24, we did 2,288 joint hip and knees, and that in 24-25 has gone up to 2,613. And for the first time in years, we're now beginning to do more joint replacements than are referred. That means that the wait list will go down. But the wait list is substantial. The active wait list was 2,645 at the end of July. The end of the financial year was over 3,000. So we're cutting into it, but we still have a very substantial wait list. There are other details that I'm not going to go into. And then when you look at cataracts, where we also have a long wait list, the number is increased by 12.5% from the 2023-24 to 24-25. And our current active wait list is 3,452. So again, we're improving in that area. And I expect to have even more improvement in that this year, because there's been agreements with the community clinics that deliver cataract surgery to do more of them. The other major initiative is around trying to ensure that there's equality of access that allows the patient to be referred, and then for the procedure to be done as fast as possible, and the right surgery is given to the right patient at the right time, and that occurs through central intake. It's just started. It started for those 2 big procedures, cataracts, to try and improve the number done, and for joint replacements to try and improve that. And you can see that the numbers of referrals and submitted to the system is enormous. And the number of referrers is 470. We've started the orthopedic central intake has just started, and currently there's over 14,000 referrals submitted into this system. The intent for this is to improve access and reduce wait times by routing referrals through a single point of entry, eliminating duplication, and allowing patients to be matched with the appropriate provider with the shortest wait time, including offering the option of alternate sites when available to avoid unnecessary delays. So this can be extrapolated to many other procedures, and that will definitely be a direction that we're going to proceed down. Now, how about cancer care? So I hope you're not getting bored now with this, because you can understand that if I don't spend some time with this, the complexity get lost. So unfortunately, you're going to have to listen to me. So here we are with our situation here in this province. You can see there that the orange diagram, we have the highest age-standardized cancer mortality in the country. And people would think of that as being, oh, that's related to we're not doing good enough care. That's not the truth. Our management of cancer is as good as anywhere else. The problem is that we've got an increased incidence. It occurs more frequently. And for us, you can see in the bottom there, cancer mortality rates for males. Look at the cancer mortality rate for lung, which is much higher than the Canadian average. And look at the cancer rate for colorectal, which is much higher than the Canadian average. And the same for women. There is a difference for lung, and there's a difference for colorectal as well. And it's driven by incidence. And the way that we can deal with incidence is to try and find cases early. And that top diagram, I won't go into it in detail, but it demonstrates that we are trying to improve our screening programs for lung cancer, for breast cancer, for colorectal cancer, and cervical cancer. Because these have got, the evidence is that these programs work. And because we've got such high rates of lung cancer because of smoking, and we've got high rates of colorectal cancer because of a number of things which include family history, we need to be able to get more effective screening programs. Here's an example of what I'm talking about. The age standardized mortality for breast cancer is high in this province compared to Canada. And you can see it's because the incidence per 100,000 females is higher than Canada, but our 5-year survival is exactly the same. So our capacity to be able to screen with more women, and women from 40 to 49 years of age, needs to improve. And you can see there in My Health NL, the ability to self-refer through My Health NL has been substantial. 2,000 patients since May 2021 have enrolled to be able to get a mammogram, which is really good. And the reports and results letter are available on My Health NL. So I think that this is a success story and will continue. And the final piece of this is the establishment of a second site for radiation oncology. The minister just gave the details of it, and this is about to start in the fall for radiation oncology on a second site in the province in Western Newfoundland. I'll move on to rural health. Because there are problems in rural Newfoundland that are not present in urban, and we have the highest rural population in the country. So are we doing anything about trying to sort out what's going on for healthcare in rural areas? We have created what we call a strategic health network, which is a provincial approach to try and solve problems that exist that are major problems. And we've had a symposium with the relevant doctors from all across the province about the issues that occur in rural health. And their biggest...
May I have your attention, please? The hospital pager system is now back in order. Please resume normal activities. The hospital paging system is now back in order. Please resume normal activities.
And you can see here that the concerns for rural Newfoundland echo the general provincial concerns, but here they are. Access to services, recruitment and retention, transportation, frail to elder care, technology and virtual care. They want technology and virtual care. And then they want to be heard, rural engagement and integration with the delivery system, such as action on the problems that they have. And as I've pointed out, we are engaged in all components of that. I'm going to provide you with data on recruitment and retention in a moment, and I'm also going to provide you with information on care of the elderly. And here it is. Now, there's an enormous amount of stuff on this slide. And rather than me going through it, you've got it in front of you, you can read it. But there is work going on in dementia-friendly communities, age-friendly communities, an age and dementia-friendly pathway within communities. And that is the dementia side. And then on the support side, the social side, there have been several grants being started. And the interesting thing here is the number of people who've availed of these grants. So the first one is Aging Well at Home is a $400 a year for people who are fit to cry, who are living at home, who are elderly and want to stay at home and need help with activities like, say, snow clearing. 5,662 people have been approved. A caregiver benefit program in which there are people who are getting substantial care in their home, delivered by their family, and there has been a monthly payment provided for those caregivers. 35 individuals have been approved. A community transportation program, 3.6 million and 27 projects, and then this one, a home repair program, 76% over 65 and 1,113 people approved for home repair. A modification program, which is in the same place, 695 people. So the numbers have been being accessed is actually quite substantial. There are 4 important vaccination programs that have been upgraded. The influenza vaccine for seniors, pneumococcal vaccine, the shingles vaccine, and the respiratory syncytial virus vaccine, all of which will prevent disease and all of which we would like more people to avail of. We need more people vaccinated. And then this one is about what do we do in hospitals. So there are centres of excellence in ageing started in Corner Brook and in St. John's. And there's 2 acute care of the elderly units started for frail elderly people who get admitted to hospital who need specialised targeted care from geriatricians to ensure they get home, not that they go on to a long-term care facility. One has been started in Western Memorial in June 2024 and has been successful, and one just started in St. Clair's. And here's the pieces of success. In the 352 admissions that were evaluated, the experience of care rating by the patient and their families was 9.5 out of 10, and the percent who returned to the community was 78%. So that's a really strong return for these care of the elderly, or acute care of the elderly units. And again, we need to strengthen our services for seniors across the care continuum, and this is where the long-term care component of it is so important. And again, I'm not going to read all this. There's been substantial work on workforce education and training, community support program, long-term care and persons, long-term care and personal care home action plans have been developed, and community-based services. These are important. That we're trying to see if it's feasible to use personal care homes to provide short stay for recovery after an acute admission, to have adult care programs so that people can stay in their homes, to enhance dementia care, and we've got pilots that demonstrate that can be effectively done in a personal care home, and then also to provide rehabilitation and restorative care to people who've just been in hospital. Again, those pilots have been successful, and we'd want to increase them. So there's been a very substantial amount of work done in the arena that is the biggest problem for this province, which is the fact that a quarter of our population are over the age of 65. They will require 4 times as much money to provide care to them than non-seniors. And this is a big issue for this province going forward. Now, what about our capacity, the pathways that are necessary to be able to allow us to deliver care as effectively and as efficiently as possible? The health information system, the EPIC system, is on target for April 2026. This is really important because it integrates people across zones, their data across zones. It integrates them across care pathways. For instance, it integrates acute care and community care and long-term care. It allows the patient to access their data, and it allows the system to be far, far more efficient than it currently is. And embedded within it, if we use it properly, are a capacity to be able to deliver interventions much more effectively to the population, so we're getting the right intervention to the right patient at the right time. This is $700 million investment over 10 years, and it has got, once the people are trained and the system goes into effect, then it's capable of having its benefits. The challenge period is in the next 9 months, because we've got to train 23,000 employees how to use this system, and then we've got to use it properly. And here is the process diagram, and that interrupted vertical line is where we are today, and you can see there in the yellow triangles that we expect to have testing of this new system where the software has been created to identify what care pathways are, that's completed, and that we're able to go live in April 2026. And at this point, I can tell you that we're on target to be able to achieve that. And that's actually, it is a drop dead date, because if they don't achieve it, I'll drop dead. This is digital health. So this was mentioned by the Minister as well, and all you need to do is look at the graph on the right-hand side. So people can enter into a website or an app to get their personal health record with results that are immediate. And you can see it's nearly 150,000 people, right? We've only got, 450,000 adults. And they're also using the web, nearly 50,000 are using an app from their phone. So I suspect some people overlap, but that's nearly 200,000 people. When we start EPIC, people will have access to a lot more information, and they'll also be capable of scheduling themselves. So that will be a distinct improvement in that as well. Now, the key pathway, I'm sure all of you would say, is what about human resources? And where do we stand on human resources? The government has increased seats for providers in Newfoundland Labrador institutions, increasing registered nurses from 340 to 360. That'll kick in this coming year. That kick in of an increase is going to have a big effect. There's also an increase in nurse practitioners, an increase in practical nurse seats, an increase in paramedics, and upgrading emergency medical responders to primary care paramedics. All of these increases in seats are about to kick in, or have kicked in already. And then on the left bottom table, you can see what's gone on in the Faculty of Medicine. And we've gone in 2022 from 60 Newfoundlanders and Labradorians of 80 seats in the medical school to this year, we will have 84 Newfoundlanders and Labradorians from a total faculty of 90. Now, they'll take time to kick in, but you can see there was an increase started in 2023. So it won't be long before we see that starting. And on top of that, for people in residency programs, we've increased the number in residency programs, and that kicks in immediately. 5 family medicine for international medical graduates, 2 internal medicine for Canadian medical graduates, 2 internal medicine for international medical graduates, expanded care of the elderly training in family medicine, and creating a geriatric training program connected with the Royal College. So all those things will have an effect in areas that we are really concerned about. They'll affect family practice, internal medicine, and geriatrics. Now, here's the last amount of data coming up, and then I'll summarize. These graphs are really important, because you can see in October 2019 that the number of vacancies for registered nurse, that's on the left, is around 250 vacancies. And then you had COVID, and the Great Resignation came in, such that the vacancies for nurses went up to 695 peak in the middle of 2022. And then you can see now that it's down at April of 2025, is down to 280. We're nearly back to where we were before COVID. And with the increased number of seats coming in the coming year, it's highly likely we're going to be in a better situation than we are in 2019. The same picture plays out for the other important areas. Licensed practical nurse practitioners on the right there, and in the next slide you can see that's the case, exact same case for LPNs and for personal care attendants. We're back to where we were for personal care attendants. We had about 60 to 80 personal care attendant vacancies in 2019, and here we are at 61 in April of 2025. And then this is the data that the Minister quoted about the increase in the number of licensed doctors compared to 2021. We've gone up by 7% number of registered. Compared to last year, we've gone up by 7% registered doctors. So I'll finish up by trying to summarize what I've stated by asking this question. Is it reasonable to think that the changes that have been brought in by the Health Accord within a short period of time, like we're ahead of schedule, within 2 years of a provincial health authority starting, should we feel that there's been a benefit to patients' health, individual patients' health? And here we are. This is an intergenerational family. My great-aunt was flown to St. John's for cardiac cath testing, is now followed by a clinic that visits her hometown and provides virtual appointments. She's improved. Our son was accepted to nursing school in Newfoundland and Labrador and plans to work in Newfoundland and Labrador when he graduates. Our daughter, who just returned to Newfoundland and Labrador, is receiving virtual primary care while on a wait list for a family care team. My wife started breast cancer screening at age 42, which is a great relief given her family history. Our son was, where's the next gone? Great Nan was in hospital in Corner Brook after she fell, but with rehabilitation she was able to return home after 10 days. Which one is next? I can't see it properly. Our great uncle received home repair support, which is allowing him to return to his own house with home care 3 hours daily. My family receives primary care from a family care team in our community. My dad received EVT for a stroke caused by a blood clot and returned home after a few days. Our whole family signed up with My Health NL and can see most lab and imaging tests without delay. My grandfather is able to walk without pain after his knee replacement. My family no longer must leave the community for emergency care because the emergency department closed. It's now open. My uncle received same-day hip replacement surgery, meaning no hospital stay. So, that's the last one. Huh? If I lost it, I'll stop there. Okay, I'll stop there. Okay, but there are several other examples of improvement to care that I mentioned. So we'll stop there and take whatever questions you want.